Run It Studios and the Arthritis Foundation of Missouri bring you this special episode of the Run Radio Podcast. Welcome back to the Run Radio Podcast. This partnership with the Arthritis Foundation of Missouri is bringing resources to you and information that can hopefully help you or a loved one that you know of that is dealing with any type of arthritis. And so I'm excited to talk to Dr. David Crane with Bluetail Medical Group. Welcome.
Thank you, Trina. Thanks for having me on.
Yeah. So tell me a little bit about what you guys do over there at Bluetail.
Well, really, Bluetail started more than 10 years ago to address chronic inflammation scenarios that weren't well addressed from typical medication usage, pharmaceutical agents like we normally would use in the past for arthritis. And we started using regenerative medicine practices to address these chronic smoldering inflammation processes that were showing up in all the joints. We're seeing a lot more arthritis development in our older population as our population ages. We're seeing arthritis at younger ages for lots of different reasons, which I'm sure we'll discuss. But really, Bluetail came out of that whole regenerative medicine origination push to address those chronic things that other things couldn't handle.
Well, let's talk about that. Why do you think we're seeing it in younger folks more than ever?
Well, I think there's a lot of potential factors, and one of the biggest problems is nobody can really put their finger on one factor that's driving the train. I think there does exist some things in our nutrition space that can create inflammation. We know that certainly I have a lot of patients who say that they will change their nutrition and some of the things they eat in their normal dietary structure, sugars, for example, or gluten for some patients are sensitive to that, or dairy for some patients are sensitive to that. Just anything that you're sensitive to. But I do think that our food sources have become a little bit more depleted in what we can do, and I think that drives inflammation. I think there's a lot more stress in our space from all kinds of things, whether that's daily life or cell phones or I don't know, but I think those are in that mix. I think really the epigenome, we know that just because you have a genetic predisposition in your family for arthritis doesn't mean that you have to activate the gene. But I think some of the things in our environment are activating those genes for arthritis formation. And I think that's really showing up in younger patients now. And we're seeing that not just in arthritis, by the way, but also in other things that are degenerative, like diabetes and hypertension and heart disease and neurodegenerative disease, and all of those things that are linked. All of those numbers are going up despite our best efforts.
And even though medicine moves pretty quickly, in reality, it also for the patient seems like forever to get anything done. What's it looking like from your perspective? How soon we're going to see some advances, and what are those going to be like? Are they going to be an impact, a big impact, or minor?
Well, I think that's a wonderful question and a great question and a little bit hard to answer, but I'll give it my best shot. So we already have seen quite a few novel approaches to arthritis in the regenerative medicine space, and we certainly have progressed significantly from where I started 20 years ago. I opened my first private clinic in 2004, so we're 20 years into this space. We are, one of the biggest problems is that our typical system has been based on pharmaceutical and small molecule, which is basically if you picked a drug, let's just pick any non-steroidal anti-inflammatory drug that you want to try to name. And we use that for arthritis. One of the things with regenerative medicine is that nobody can patent your own stem cells or own stem cells or own anything that's a biologic from a human. You can't patent that and make money on it. So pharma really hasn't had their hand in the cookie jar yet. Pharma and the FDA have certainly started to come out with regulatory and compliance things that are going to make this area safe for the consumer. I think that's wonderful. I think that as we see some of those pharma, starts to get out of the small molecule into what we call the large molecule or biologic space, and we're seeing many, many more biologics now. The COVID vaccines are biologics. The A lot of the new cancer drugs are biologics. A lot of new arthritis drugs are biologics. I think as we see all those biologics come into the space, that's going to dovetail into the regenerative medicine space. And I think that will then go to Medicare for subsequent funding allotments. And then, all the other private insurers follow Medicare. And so when Medicare really approves sort of the payment for these things, then I think you'll start to really see the advancements come more quickly. And we're right at that inflection point now. We're just, we've been doing this 20 years. The average time it takes for a novel approach to really get set up in medicine is 18 years, I think is the number. And so truly we are seeing this, we're 18 to 20 years in, right at the time when it's supposed to happen. We're seeing this inflection point where all these new technologies are really starting to hit the patient space in a meaningful way.
Excellent. So what would somebody come to you for specifically, and what would that be? What's that experience like?
We see the thing that we see the most in our clinic is really knee osteoarthritis. Knee arthritis is so prevalent. We're seeing it again in 30s and 40-year-olds now. When I was a fellow, I would have seen it in 50s and 60s or 70s. And we also see then a lot of post-traumatic arthritis after injury, like an ACL injury or chronic meniscal injury or those things. So that's by far and away the thing that we see the most of. We also see a lot of other arthritis like hips and shoulders, and we do degenerative disc disease and other things. But our knee arthritis, if you are asking that question, is really the thing we see the most. We really have to have a discussion around what has the patient tried from less aggressive to more aggressive.
Mm-hmm.
There's a lot of things that kind of have lived in that space, whether that's physical therapy or, the other pain medications like Tylenol and nonsteroidal medications like ibuprofens and things. And then we work on other medications that have some utility, whether that's the viscosupplementation things like that some insurers are still paying for, some aren't. And then we start to look at the regenerative medicine space where we live. And most of the time, the patients who come to us have already been through all of those less aggressive approaches and haven't had that much success, or they've had success for years and now they're starting to progress beyond those steroid injections or whatever that may be.
Yeah. And
then we sort of have to make a good relationship with that patient and help them understand if that patient needs to go on to having something like a joint replacement or something like that, which is the most aggressive approach in arthritis, but certainly has been a safe and certainly approach that a lot of patients have required for really severe arthritis. And I think that all of those options for us need to be scripted and on the table for the patient. We just have to help navigate that roadmap for people.
Yeah. And I know you said osteo is what you see a lot of. Do you do much with rheumatoid patients?
We do. Rheumatoid, again, for me, the way I like to talk about arthritis is really sort of this script. And I want to sort of use what I would typically tell a patient because I think it is meaningful. I think of arthritis as a chronic smoldering inflammation that eats the nutrition from the joint. And we've learned over the years that there's a lot of stem cell reservoirs around your joint. I hear a lot there's a lot of sort of misinformation out there that all of our stem cells, we don't have stem cells as we age, and that's not true. Every couple of years, our joints have to completely turn over. So there's always a repair process going on around the parts of our body that need repair, which is every single cell in our body. And around the joints, there's particular stem cell reservoirs or reservoirs of regenerative pockets. And they exist in fat, and they exist in bone marrow, and they exist in the synovial fluid. And once you deplete that resource pool with chronic smoldering inflammation, you'll see arthritis take off and get really bad very quickly. And I have a lot of patients who come in and they're surprised to find out that their other knee has arthritis in it, even though it doesn't hurt. But our bodies are wonderful in trying to be resilient for us and keep the things out of our space. And so our bodies will do everything it can until it finally runs out of the resources it can do repair with. And then we'll start to get inflammation and degeneration, and it hurts. And so we're trying to capture some of those patients before they ever hit that stage, because the earlier we capture them, the better. So referencing back to your discussion around rheumatoid arthritis, I think it's sort of some of the same talk. There's an autoimmune component, meaning your body has set up this immune response to your own cells, and that creates the chronic smoldering inflammation. And that starts to eat the nutrition from the joint. And in the regenerative medicine space, whether or not we talk about, lots of different tools in that regenerative medicine space, which we can get to. But all of that is designed to put resources back in the joint for your body to do repair with and work with to do repair. And I just think what I tell patients is that's why we sleep at night. We sleep to do repair and integrate. And so if you're not sleeping, you're not regenerating. If you don't have good nutrition, you're not regenerating. If you're overusing the joint with trauma, or a ballistic load, you're not going to regenerate. And so the same thing happens with autoimmune disease. If that autoimmune disease is just on fire, we have to help shut down that autoimmune response, which is rheumatoid arthritis, and get that resource pull back.
Well, let's talk about some of those tools you just referenced. What is that all about?
Well, it's certainly expanding. That's one of the talks, like you mentioned earlier, questions you had earlier about what's sort of showing up in the space. For the last 20 years, we've used platelet-rich plasma. PRP is kind of in the lingo of our jargon. And platelet-rich plasma just utilizes a bunch of growth factors that we borrow from the patient themselves. So it's considered autologous, which means it comes from the patient source. And we also use bone marrow aspirate grafts, which do have stem cells in them. Stem cells is really kind of a naughty or dirty word in the pharma or the FDA space. We're all very careful about how we use that term. Stem cells are, in order to be called a stem cell, you have to be able to do very, very specific things. And I think there's a lot of misinformation out there that patients really need to understand if they're going to go down the regenerative medicine pathway, to understand what tool they're working with. Now we're seeing more in the space of extracellular vesicles and growth factors that are acellular, which means there's no cell wall, but they interact with the other cells in the joint and tell those cells to become less inflammatory, and they can give back some resources and drive resources back into the resource pools. I think those extracellular vesicles, in the colloquial space, they're called exosomes, which patients might hear that word. And then there's other things like adipose, or using fat-derived stem cells. And there's a lot of stem cells that live in our body in both the bone marrow space and the fat space. We have adipose in our bodies, which I always tell people, like, the fat is not the F word, right? It's got a lot of wonderful utility. It has a lot of hormones. It's got a lot of resources like stem cells. So fat is actually a great tool for us to utilize, because a lot of people want to get rid of it. So we're happy to use it.
Excellent. So what are some of those misconceptions that you could kind of clear up so the patient understands stem cells a little bit better from this conversation?
Yeah, another great question. Thank you. I think a lot of the misperceptions happen around the education of what companies have tried to push into the typical landscape. A lot of that, again, had to do with, you're too old, your stem cells are too old or too weary. And that's not particularly true, although the reference I use is, if you have a lot of fires burning, meaning if you have rheumatoid arthritis and you have hypertension and you have diabetes and you have other fires lit, it takes more resources to go start the repair process for a knee joint, et cetera, or a disc, or et cetera. So I think the misperceptions about that are rampant. I think truly, patients need to understand what apples and oranges, meaning, like, there's a lot of growth factor stuff out there. There's a lot of stem cell stuff that is done in the higher end clinics. And unfortunately, it's kind of one of those things that right now, since a lot of it, private insurers won't pay for this, they're expensive. And so the stem cells are more expensive, and so I think a lot of patients shy away because of the cost, and that's certainly an appropriate argument until Medicare gets involved. I think the fact that stem cells are required to work over a period of time, they're not like a steroid shot. When we put that in, we expect your pain to go away very quickly within a day or two. Regenerative medicine techniques really require months for that to take effect. And so we really have to have, again, we have to use all the tools in our toolkit, whether that's things to help their pain while the regenerative medicine process is working in that joint, because it does take months for that sort of pain relief to show up. And then the other thing is that we really want to sort of capture patients when they're in that mild to moderate arthritis phase, and I don't like the language of bone on bone. I think that language doesn't suit us anymore. But if you're in that so-called bone on bone, just severe arthritis space, then you may be better served with having a more advanced surgical technique. And that's just something that, stem cells aren't going to help everyone. And I think there's a lot of misperceptions and a lot of marketing out there that says, oh, I'm going to put this in your joint, you're going to be better 100%, and it never fails, and all that stuff. So that's not true.
And how does someone know if they're getting the right information? If maybe they're thinking, I'm not ready for surgery yet, but they're worried they're too far gone to see you. Should they come have the discussion with you first before going under the knife?
I tell my family that. And so I would say on this podcast, like anything I'm going to tell my family, I'm going to tell my patients. And for sure. I mean, I think we are we are not surgeons at Bluetail, and we don't pretend to be surgeons, and we don't desire to be surgeons. What we desire to be is a patient advocate. I think patients really do need more advocacy out there
Yes.
from both the providers and their family members and everything. Medicine has really had a lack of patient advocacy, and I think that needs to be addressed. So we are very happy to see them on an insurance basis, meaning we can do all their evaluations with insurance, and we can do ultrasounds, and we can do x-rays, and we can do a physical exam, and we can determine where they are in the spectrum of arthritis, whether it's, none or mild or moderate or severe. And we can just lay out all of the different options that currently exist in the space, whether that's, again, they haven't started in the osteoarthritis treatment protocol yet, or they're down the road and they've already tried a bunch of different things. But there's almost always something that we can offer advice-wise or treatment-wise to get them some pain relief until we can get them in a place where they can have joy in their life again. My whole scripting is around, you got to have joy in your life. If you don't have joy in your life, then we have to go to the next thing and find that joy back, because nobody wants to live without joy in their life.
No, and pain will suck that joy right out of you faster than anything.
Yep.
So let's talk about another great resource that we've got here in Missouri, and that is the Arthritis Foundation. The Missouri chapter does great things. What's your involvement been with them?
Well, really, to be honest, we just have started to partner with the Missouri Arthritis Foundation. And I really, again, we talked about that advocacy piece a bit. I think for me, as I get more mature in my career, in my own life, and I have arthritis in my family, and I've had arthritis myself, so I've had all these treatments on myself. I really do feel like my family and my patients and my community needs a really good resource for advocacy. And I think the Missouri Arthritis Foundation does that extremely well. And that's really a wonderful resource for patients to have.
Absolutely. All right. Tell people where they can go to learn more about Bluetail Medical Group and get in contact with you if they need information.
Yep, we're at www.bluetailmedicalgroup.com, and you are always happy to call in and talk to any of our staff members. They are all very polite, and we are happy to talk with anybody who wants to talk with us.
Thank you so much for giving us a little peek into that world and providing us with some insight. Appreciate what you're doing for the arthritis community and everybody else that can benefit from your services.
Thank you, Trina. Wonderful.
Have a great day, and thank you so much for listening. You can watch the video, link over to whichever platform you prefer from runradio.net.